لكل الحضور. شكرا على حضوركم. اليوم عنا توبيك بالريتنا صراحة، يعني في نقول أنا صار لي أكثر من أسبوع متشوق إنه حتى أسمع الليكتشرز. very hot topic, very important و very يعني في نقول له علاقة كثير بالكلينيكال يعني براكتس بالشام وحتى بأمريكا وين ما كان. أول اليوم رح نحكي عن عمليا عن انفصال الشبكية. رح يحكي دكتور طارق أسيل عن موضوع انفصال الشبكية بشكل عام والعلامات اللي نشوفها بالفحص اللي ممكن فينا نقول تدل إنه ممكن هالمريض هذا يصير معه انفصال شبكية بالمستقبل. وبعدها دكتور كمان شحن رح يحكينا شوي عن بعض علاجات الانفصال الشبكية سبيسيفيكلي على نيوماتيك ريتينوباكسي، انفصال علاج انفصال الشبكية عن طريق النيوماتيك ريتينوباكسي. very hot topic. دكتور طارق ما شاء الله يعني صراحة السي في از فيري يعني ما شاء الله يعني لونج وكلها اتشيفمنتس. ما شاء الله دكتور شام كمان فيري سيميلر، حتى ما شاء الله اثنين ما كنت بعرف تفاصيل يعني بس من قبل، بس عم اقرا السي في في كثير سيميلاريتيز، بس شو بيرفع الراس صراحة. دكتور طارق خلص الميديسن بجامعة حلب، بعدين سوى فيلوشيب ريسيرش فيلوشيب بكاليفورنيا، بعدين هي جويند سوى ميديسن ريزيدنسي بالداخلية بالايست كوست، راح الايست كوست على بوسطن. بعدين هي سوى هني كمان some research fellowships بهارفارد. بعدين he joined a very prestigious residency program بالعينية Yale University, and then he رجع مرة ثانية على كاليفورنيا and he did his training ب Retinal Institute of California. حاليا هلا دكتور طارق بكاليفورنيا his practice وعنده almost 10 years of experience ما شاء الله. So we're very happy to have him, very happy to get some his experience و approach about this very very hot topic. تفضل دكتور طارق.
Hello everyone. شكرا على الاستضافة للسامز و thank you for the introduction. It's my pleasure to discuss surgical approach in retinal detachment repair, which is a dear topic to my heart. راح أحاول يكون في شوي surgical videos to keep it more clinically and surgically focused. Of course, there are going to be some slides for presentations, and we'll take it as it goes. Of course, retinal breaks are the main issue in rhegmatogenous retinal detachment, where you have full thickness defect in the neurosensory retina that sometimes is caused by atrophy or traction. What the gel واللي هو الخلط الزجاجي or vitreous is pulling on the retina. The retinal breaks can come in different shapes. It can be a horseshoe tear, which we all know and we've seen before in our exams. And the thing with the horseshoe tear is that you have some vitreous gel is pulling on the edge of the horseshoe tear. It can keep extending, and when it lifts the horseshoe tear, it allows liquefied vitreous to go underneath the retina, and that can result in the retinal detachment. Of course, the retinal tear can be large or giant when it's extending 90 degrees or 3 clock hours on the exam. هحاول أفرجي فيديو عن surgical management of giant retinal tears. وفي operculated holes واللي هن traction is sufficient to tear a piece of retina, which releases the traction. So this is a very low risk for retinal detachment. وفي dialysis, where you have a circumferential linear break at the ora serrata. Recently, I did a case of retinal dialysis repair, and the teaching tells you that scleral buckle is the best approach. Unfortunately, the patient كان عنده keratoconus with a full thickness cornea transplant, but the view was very hazy through the surgical microscope. So I barely made the retina attach, and then I put silicone, but he needs a corneal transplant, a repeat corneal transplant. The atrophic retinal holes, which we also encountered during our exams. And of course, we can talk a little bit about macular holes, which is another dear topic to my heart. So these are some examples of retinal breaks where you can see the horseshoe tear. And as the name implies, it's almost like a horseshoe. And you can see the flap that is sometimes pulls up because there's always gel or vitreous gel attached to the tip of the tear, and it keeps pulling on it. And you notice that better with surgery. Of course, there are giant retinal tears. I'm going to present a surgical video about that, where it's extending more than 3 clock hours. And there are specific surgical techniques to tackle these giant retinal tears. Operculated holes is where you see the floating operculum that has already pulled away from the retina. So the traction has been released. And then the dialysis, as I mentioned, is circumferential linear break at the ora serrata. And given the nature of it, that's why scleral buckle is the best recommended surgical approach in these cases. And these are more examples of retinal breaks.
اوكي مبين في نوع من الاجريمنت على الجواب.
Good. Should I move to the next question?
يا تفضل بس.
Sure. I think we're going to move to the next one.
The next question. Yes. اوكي اتوقع فينا لازم نقول على next question.
All right, and now the last question. All right, so I'm gonna move now to some of the surgical videos that I have. I'm gonna start with a surgical video for management of giant retinal tear. This case was done about 5 years ago. For the volume, as you can see, the giant retinal tear is folding the retina, so it's almost like a taco. And then here we start with vitrectomy at the edge of the folded retina. You can see the thick vitreous that is like attached to the retina edges. You can see a glimpse of the optic nerve under the folded retina. And on the bottom here, you can see just with the retina folded. How is the view on your end?
الفيو منيح صراحة، الفيو كتير.
It's a dark video. The other videos hopefully are a bit more clear. Here using ILM forceps, trying to hold the edge of the giant retinal tear or the retina that is folded, trying to folding it back in place. I utilize 23 gauge vitrectomy in all my cases. I've done some 25 gauge, but this is 23 gauge. Now you can see the optic nerve, the arcade, still trying to eat the gel that is pulling on the retina edge. Now applying a PFCL, it's a heavy liquid, in order to protect the macula, flatten the retina. And this is going to open the retina into attached position, which will allow you to laser at the end. So almost here in this case, I did a 360 endo laser. And this is PFO. In this specific case, I left the PFO in the eye for 1 week in order to keep the retina intact while the laser scars are healing. And then after a week, I brought the patient back for PFO, hair fluid exchange, and then put silicone off. And she's attached to date. And her vision is like 20/30 or 20/40. So this is the placing of the ports, and then the retina is completely detached. And here, I'm trying to hold on the vitreous. It's almost an incomplete PVD. Trying to induce a full PVD. You can see the tear is temporal. It's a horseshoe tear. So here you can see that the patient developed, I'm going to stop the video. The patient developed a little choroidal intraoperative while I was applying suction. Let me just play it again. So now we're trying to suck fluid from the retinal break in order to release some of the suction fluid. While we're doing this, it's forming choroidal. At this point, I stopped, and then I moved my light pipe to the right side to visualize better the choroidal that developed. And the reason for this choroidal happening is the perfusion line was not perfusing into the vitreous cavity, infusing into the suprachoroidal space. So I had to move the infusion nasally in order to perfuse the retina again. I mean, perfuse the vitreous cavity and flatten the retina. As you can see here, the retina is back in position and the choroidals have subsided. Now trying to slowly shave the vitreous 360 degrees. You can see the break, and also you can see a bunch of lattice degeneration كورويدلز، ما بعرف شو المصطلح العربي بيقولوا له.
انفصال المشيمية.
maybe دكتور شهم he knows كورويدلز.
إيه مثل ما قال الدكتور مروان، انفصال المشيمية.
انفصال المشيمية basically yeah. اللي صار خلال وقت كنا عم نحاول ناخد الفلويد من تحت الشبكية to suck it with a retractor، فصار انفصال مشيمية. والسبب اللي صار هو انه الانفيوجن لاين اللي حطيناه هو كان already perfusing بالفيتريس كافيتي بجوات العين، بس صار هلا بسبب انه انفصال الشبكية كان كبير، صار الانفيوجن لاين عم بحقن فلويد يعني بالسبريتنال سبيس. so we had to move the infusion line to the right in order to لحتى نخلي الفلويد تدخل لجوات الفيتريس كافيتي وتقاوم انفصال المشيمية وترجعه لمحله. هلا هون رجع الوضع under control. You can see still the retina is detached but the انفصال المشيمية تم تدبيره. هون we're using cautery يعني مشان نعلم محل الريتينال بريك، لأنه بعدين وقت بتقلب من سوائل الهواء بصير صعب أحيانا نشوف وين البريك. هلا هون eating the lip of the break يعني هذا horseshoe tear. We did this لحتى to relieve any more traction على اللب تبع الhorseshoe tear. هلا هون عم نقلب من fluid ل air. الاير بيساعد to apply، يعني الهواء بيساعد apply tamponade يثبت الريتنا. هون ليزر اندو ليزر حوالين الريتينال بريكس to seal the brain. وكمان ليزر للارياز اللي فيها lattice degeneration واللي فيها micro breaks small breaks. when drying more of the fluids. وadding كمان more laser. بعدين we put gas C3F8 14%. Good schematic of different retinal breaks. And that one in horseshoe tear breaks, then they can come in a larger size. Also, the retinal tear at the posterior border of the vitreous base. By the way, the vitreous gel is most strongly attached at the vitreous base. And that's why we always try to shave the vitreous gel all the way 360 degrees because هالمناطق بيكون دايما potentials for more breaks بالمستقبل وممكن يؤدي ل redetachment، يعني ترجع تنفصل الشبكية بعد ما عملنا العمل الجراحي. هلا بالنسبة للتراما and retinal breaks, blunt trauma can definitely cause retinal breaks by either coup or counter coup, which means يعني قوة مباشرة على بتؤدي ل retinal break أو بسبب قوة مباشرة بتؤدي ل putting some pressure on the gel, and then the gel will retract. And when the gel retracts, a bit, الخلطة الزجاجية retract, it will cause a retinal break. So in young patients يعني اللي عمرهم بالعشرينات الثلاثينات الفيتريوس لساته هلامي وفورمد ما فيه هسه كتير سينريسيس وليكويفيكيشن. مشان هيك in these patients especially وقت بيكونوا فيكك يعني هسه عندهم الاوريجينال لينس ما عملوا cataract surgery بيجي عندهم break with a retinal detachment, it's very important to consider scleral buckle. لأنه the buckle basically will support the vitreous base. Some of those patients may be high myope, عندهم breaks, inferior, multiple micro breaks. Or in this case, when you do a buckle, you haven't like invaded into the vitreous gel. And the beauty of the buckle is when you're changing the shape of the eyeball in a way that you're supporting the attachment between the RPE or retina itself. It's always important to document the status تبع posterior vitreous, if it's detached or not, if you see a PVD or not, because this is important in retinal detachment and in making decisions in or out. رح تاخد vitrectomy ولا رح تعمل buckle ولا combined in some cases. بس ده أسأله إبراهيم if everybody can hear me.
Yes, we can.
Okay. So
بس فيك
بيجي
إذا فيك
كتير
تعلق
ترى
بس
كيف
صوت الدكتور.
شو بالعاده
كيف؟
بتساوي حتى تتاكد انه المريض عنده بي في دي بالفحص؟ يعني مثلا عندك مريض اجى على العياده وبدك تسوي له عمليه انفصال شبكيه، في تريكس او تيبس مثلا ممكن تفيدنا فيهم؟
هلا of
كيف
course your
نتاكد
dilated
انه عنده
fundus
بي في دي؟
exam والindirect ophthalmoscopy and then the gold standards for the exam. You try to document the status تبع PVD or also to find all the breaks during your exams. But in all honesty أحيانا you see that during the surgery itself. يعني هلا شد ما عملت أحيانا thorough exam أحيانا إذا retina detachment is bullous أحيانا بتكون مخبية other breaks. But when you go to surgery and you start flattening the retina a little bit بلش بتشوف البريكس التانيين المخبيين. You do your best in the clinic in order to find all the breaks, but there might be others that you will discover during surgery. But you're trying to do your homework in the clinic in order to decide the best surgical intervention للpatient وتاخده على OR. هلا هون want to name the 3 retinal lesions اللي هن high risk ليؤدوا ل retinal detachment. Of course the lattice degeneration, and lattice degeneration بنشوفها عند عالم بيكونوا high myope أحيانا بنشوف عندهم they start developing micro breaks, وهالmicro breaks بالريتنا ممكن يؤدوا ل some of the fluid to travel through the breaks and underneath the retina and cause a retinal detachment. And also the vitreoretinal tufts, because they have some sort of attraction من الvitreous gel على الشبكية وmeridonial folds as well. This is an example of lattice degeneration. هذا أكيد كلنا بنشوفه بالأوفيس وممكن نشوفها ب 6 to 10% of the population. وبنشوفها more بالpatient بيكونوا high myope. هي ممكن تؤدي ل micro breaks that they form afterwards and it can lead to a retinal detachment. هلا prophylactic laser هون كاتبين إنه not usually recommended, بس بصراحة إذا أجى patient عنده symptoms, flashes of light, or that are new and you don't find a retinal detachment, I usually laser around these, especially if there is a micro break, because you want to decrease the risk for retinal detachment. And it's a quick procedure you can do in the office. It takes less than 3 minutes, as long as the patient is dilated. التufts and basically some glial hyperplasia وفي firm adherence of the vitreous to the retina. By the way, when we go to meetings and stuff, we always talk about the retinal detachment. The main thing هو abnormal relationship between the vitreous and the retina. Like in a lot of people, they form a PVD, posterior vitreous detachment, at they age in their 50s and their 60s, and it goes peacefully because the gel separates peacefully from the retina, doesn't cause a break, everything is good. But in some patients where there is an abnormal relationship between the vitreous and the retina, as the gel is shrinking with age and it pulls on the retina, then it can cause retinal tear, it can cause problems. So the traction between the vitreous and the retina is really important. And then these are meridional folds, which are basically enclosed aura bays. To be honest, I mean, you don't see those unless you really do scleral depression on every patient. But these are known to be a high risk also for retinal detachments. And this is a good schematic of it. Lesions that are not high risk for detachment. Paving stone degeneration. We all see it in some elderly patients in hospital clinic, we have paving stone degeneration. So it's kind of, we just reassure them, you know, it looks fine. It's not a high risk for retinal detachment. RPE hyperplasia, RPE hypertrophy, or peripheral cystoid degeneration.
شو دكتور طارق العادة إذا جاك مريض عنده flashing lights ومثلا عمره بال50s وفحصته ولسه البي في دي ما له كومبليت مثلا، شو شو بتنصح عن الحوار بموضوع الفحص انه ديو مثلا تفحصه
That's a
مثلا
great question.
بال90 تفحصه بال20
You have to do a thorough exam, تعمل scleral depression to make sure you're not missing any breaks in the periphery. But if you don't see breaks, you can reassure them. Probably they're having the flashes of light because the PVD is forming. So it's happening in progress. وهدول البيشنت على الأغلب بحاول أرجع أفحصهم بعد 3 أو 4 أسابيع. لأنه الجel is slowly separating from the retina. Right now, maybe today ما في retinal break. بس بجوز in a week, they might develop a retinal break as the gel is still pulling on the retina. So I usually bring them back in like 3 to 4 weeks and do another dilated exam. And in most cases من هدول المرضى بيقولوا لك انه والله flashes of light it's getting better. Now I see a big floater يعني خلاص انفصل ال PVD completely. They're seeing the back edge of the vitreous. It's a big floater moving around. وحتى بكتير عالم شوي floater it might settle down with gravity. It's not in the visual axis. أو حتى إذا هي ال PVD floater جاي exactly on the optic nerve يعني, so it's in the blind spot, it doesn't bother them, so it goes okay. But in very small percentage of cases, you will see maybe they will develop a break. Another hint is also to look for blood. If you have a hemorrhagic PVD يعني PVD عم بتشكل مع شوية bleed, this is a higher risk لأنه ما دام في a little bleed معناتها there has been some pull on the tiny vessels, and that's why what عم بيصير PVD it pull on the vessel and it bled a little bit. So you have to take a thorough look to make sure إنه مانك you're missing any retinal breaks.
هو مسائل صراحة يمكن تكون يعني مسائل من قبل أو تنعمل من قبل. بتوقع يمكن بالشام الموضوع فحص الشبكية عم يكون في إشكال إنه يمكن ما في يعني ما عم يكون كثير في اكسبيرينس موضوع الاندايركت ثالموسكوب. برأيك ممكن في طريقة تانية حتى نشوف البريفري من دون ما يكون عندنا اندايركت ثالموسكوب؟
هلا بإمكانك تعمل سوبر فيلد على سليت لامب إذا عندهم سليت لامب وسوبر فيلد lens if you're experienced and you try to look into the periphery. هلا بإمكانك كمان إذا في B scan ultrasound to look for any subtle retinal detachment. بس أنا بصراحة my personal preference هو indirect. I think indirect يعني if you have at least one in an eye clinic, I mean, I know probably it's expensive, but يعني I think it's a must for a retina specialist. يعني I can't imagine my life without an indirect, to be honest. But you can do the slit lamp, you can do the super field lens and try to look in the periphery for any breaks. ما بعرف شو ال availabilities للequipments بالشام أو بحلب أو بقية مناطق سوريا. Sorry, did I answer your question?
Yes, Dr. Tarek.
So these are some examples كمان on RPE hyperplasia. أحيانا بتكون بتفحص مريض تشوف ال RPE hyperplasia and then you start asking them, did you have laser before or did you have cryo before? And they say no, but it's just basically retinal pigment epithelium cell that proliferate and they have hyperplasia in the periphery. They are very, very low risk for retinal detachment. We just watch them. يعني we reassure the patient إنه راح نراقبكم نفحصكم بعد فترة بس it's not a high risk in retinal detachment. Peripheral cystoid degeneration also not a high risk for retinal detachment. So هون عم بحكوا على prophylactic treatment of retinal breaks. هلا in reality most breaks don't cause retinal detachment. إذا ما في traction on the edge of the break or liquefied vitreous that will travel underneath the break and cause retinal detachment. بس the recommendation or the gold standard of practice هو إنك تعمل barrier scar تخلق scar بين الليزر حوالين التير to decrease the chance نقص فرصة إنه الريتنا will separate from retinal pigment epithelium بالfuture. You can تقدر تحقق هالشيء بالليزر photocoagulation or بالcryopraxy. هلا بيجيك patient عنده acute symptomatic break يعني أجا بنيو onset flashes of light or floaters وبتفحصه وبتشوف عنده breaks. You have to treat that break especially إذا البريك لساته fresh ما في detachment around it. إذا بتعمل الليزر right away الليزر بياخد لأنه الليزر will work better إذا كان لسه الريتنا اتاتش وقت بصير بلش عندك فلويد نزلت تحت البريك حوالين البريك تضطر توسع الليزر لأنه الليزر ما راح ياخد مناطق اللي فيها small subretinal fluid تحت الريتنا ف that's why it's kind of urgent to laser those right away. كمان high risk إذا عندك patient عندهم high myopia أو إذا عندهم retinal detachment بالعين الثانية أو إذا عندهم family history أبوهم أخوهم أمهم عندهم retinal detachment أو إذا عملوا إن cataract surgery من قبل عندهم أو حتى عملوا cataract surgery ما حطوا lens أي faking لأنه هدول اللي عملوا cataract surgery أحيانا بيكون عندهم micro breaks that happens during the process of the phacoemulsification. Okay, so some traction forces. So it's very important to treat those. So I had a good example of a horseshoe tear surrounded with good laser. They did almost 2 or 3 rows من laser photocoagulation. I had a good schematic of the cryoprobe, how you apply it in order to freeze, and that will try to create some sort of a scarring between the retina والretinal pigment epithelium underneath it. So هلا الريتينال ديتاتشمنت او انفصال الشبكيه بيجي بثلاث انواع. ريجماتوجينس هو اللي بسبب انه الجل صار فيه liquefaction وفي retinal breaks والفلويد عم تدخل underneath the break causing retinal detachment. Tractional هو we see in diabetics. I'm pretty sure بسوريا كتير بيكون advanced diabetes وما under control ما managed. Some of those patients بصير عندهم neovascularization, abnormal vessels, tufts of MVs. هدول they will start oozing and bleeding. Blood will form a scar. The scar راح to shrink, like when you have a scar on your skin, similar concept inside the eye. Or when it shrinks, start putting traction and pull on the retina and pull it up. And of course, the longer you keep it without intervention, the more complex the case will be and the visual prognosis راح يكون أقل. الexudative retinal detachment هي بصير عندك retinal or choroidal disease or sometimes systemic disease بيؤدي إنه الفلويد تتجمع تحت الريتنا. And I can't emphasize enough إنه to define what type إنه تحدد هنا نوع من انفصال الشبكية you are dealing with. لأنه مثلا exudative you should not operate on these. You should try to find the cause. تعرف السبب اللي أدى لهالchoroidal or retinal disease or systemic disease وتعالجه rather than to operate. لأنه تعمل operation or exudative, you're going to try to create drainage retinotomy, create a break in a patient that didn't need this. So that opens a bag of worms. And so عرضنا مثال على rectal heterogeneous retinal detachment.
دكتور طارق، في طريقه يعني تنصح فيها to differentiate between الانفصال الشبكيه recombatogenesis induced by نقول بريك او حتى تير بالشبكيه او يعني
That's a great question. هلا طبعا الفحص بالاول، بس كمان بموضوع exudative retinal detachment shifting fluids. احيانا تحط المريض مثلا sitting position، بتشوف الريتينال detachment مثلا inferior، بعدين بتحطهم laying position، يعني بتشطح الكرسي الاكزام، تطلع انه الفلويد shifted، فهذا it's a sign of possible exudative retinal detachment. of course لازم تاخد قصة سريرية انه البيشنت اذا عنده امراض تانية عنده. وبصراحة اذا في عندك case in question it never hurts انه تعطي short course of steroids اذا ما كان في contraindication، يعني blood sugar is okay, blood pressure is okay. لانه انا عندي كذا couple of patients عندهم exudative RD. Every time I give them a course of steroids they will improve a little bit, and then when you wean them off the steroids they start building up the fluid again. Right? It's similar to like VKH concept. يعني it's similar how you see exudative RDs with VKH. It's similar. And طبعا لازم تفحص البيشنت تتأكد انه ما في breaks, that you're not missing a rheumatogenic component, ما في traction. So exam is a key. But usually exudative بتطلع تشوف retinal detachment shifting fluid وما في break. والtraction بصراحة detachment ما بتخبي حالها. يعني when you examine the patient you're gonna see full blown proliferative diabetic retinopathy مع neovascularization مع traction along the arcades on the nerve and pulling the macula up. So it's kind of very easy to see tractional. Did that answer your question?
yes شكرا.
هلا I think it's very important to talk about proliferative vitreoretinopathy. When we operate on retinal detachment, بصراحة by the end of surgery you look at the retina, it's flat, attached, you laser the brakes and you put tamponade, let's say it's gas, and then the gas like lasts in the eye for 6 weeks or 6 to 8 weeks. بعدين بيروح الgas, the retina is attached. بعدين a couple months or later بيجي patient another retinal detachment. So it's the most common cause of failure following surgical repair of a retinal detachment. And ايش بصير retinal pigment epithelium or glial cells and other cells will start growing and migrate on both the inner and outer retinal surfaces and on the vitreous face, forming some sort of membrane. And the membranes will start pulling on the retina. And with the contraction of these, they're going to cause fixed retinal folds, detachment again of the retina. It's kind of frustrating. So one of the people that I trained with told me that when you do your laser, Tamil laser during surgery, you don't want to do very much of a heavy laser, and you want to do the right amount of laser photocoagulation when you're sealing the brakes. لأنه heavy laser by itself ممكن to induce proliferative vitreoretinopathy. Some people, they mount more inflammation than others, and they develop more proliferative vitreoretinopathy, which is a PVR, and they will be at risk for. في clinical trials, some people are trying methotrexate, which is an immunomodulator injections, in order to decrease the risk. But it's still not like common practice, and you have to try to know which patient. For example, إذا جاء patient عنده أول عين صار عنده retinal detachment وصار عنده PVR، هلا العين الثاني عنده retinal detachment, maybe you will consider methotrexate injections. I know you know this patient is a very high risk يعمل PVR وعنده high risk to have a repeat retinal detachment. So again, the management is to find all the breaks, create chorioretinal scar around each break, and bring the retina and choroid RPE in contact with each other. بالنسبة لموضوع النيوماتيك, I'm going to leave this to my colleague, Dr. Shahm. He's going to talk about this more in details. Scleral buckle, I don't know if Sham is gonna cover more on that, or but I wanted to show, this is schematic of pars plana vitrectomy showing how you're putting. One of the questions that I had was, what is God's gift to the vitreoretinal surgeon? And I strongly believe it's the pars plana. لأنه البارس plana هي avascular, or retina hasn't started yet. So it's our access to go into the eye to do a vitrectomy. والمنيح بالبارس plana انه you can utilize it in a 360 degrees. يعني ما في والله مثلا you have to put it at specific clock hours. Sometimes you rotate يعني، وحتى إذا صار عندك choroidals مثل the first case I had to move my infusion to nasal, and sometimes I had to move my ports accordingly. So I think this is very important to know that the pars plana gives us a lot of room to maneuver. So hey patient صار عندها عملت لها autologous retinal transplant, بس then she developed what we call PVR, peripheral visual retinopathy, retinal detachment. We'll hole opened again. So I'm just gonna show, we started this العملية by removing the silicone oil. وبعدين we managed the retinal detachment with retinectomy. We created another retinal transplant. So let me show this case. هون بتشوف لسه في macular hole وعندها PVR. هلا هون I am using that I was describing. You can see how المembranes كلها pulling traction. هون trying to create a retinal transplant من detached nasal retina. هون using scissors, cut piece of the retina. Of course, we must first apply it together. We're applying PFO, which is a heavy liquid, at an macula, and it's easier to move the transplant on a bed of PFO, so it's not floating around in your vitreous cavity. On using a finesse loop guiding the transplant, you can see I'm moving it under the PFO into a heavy liquid. بعدين ناخذ the transplant of the retina to cover the macula. Now target position. بعدين هون applying endo laser around the before the PPR. The whole in the retina was contracted nasal, so I had to do cautery and retinectomy, which is gonna release هالبول اللي كان على الريتنا هو high risk retinal detachment. فأما تعمل retinectomy you have to keep the anterior retina، لأنه هاي الانterior retina هي high risk for PVR which is through a peripheral visual retinopathy. بعدين extending on a laser around المحل اللي أخذنا منه transplant. هون again من مد الريتنكتومي all the way using vitrector to cut the retina. You can see how the traction هذا راح يساعد الريتنا. هون extending the PFO حتى to flatten the edge for applying. بعدين بالأخير you add silicone oil. وأبدأ silicone oil. You don't want the on the the transplant in position. Oh, this is the retina attached under silicone oil. This is another picture of the transplant in position. The patient vision is like 2400. I mean, better than hand motion when she presented before this surgery. I'm gonna show one last example from last week.
يعني بس اني رح اسوي بس في طارق كنت مراجعه بسيطه للفيديو انا كان عم يقطع الصوت. يعني
اوكي.
عمليا اللي سويته دكتور طارق انه مريض كان عنده بي في ار، كان عنده مثل يعني فينا نقول سكار تشو عم يصير في تراكشن وعم يصير في انفصال شبكيه بسببه. حاولت بخلال الفيتراكتومي انه تو ريليس التراكشن او تقوم التراكشن عن طريق اول شيء الفورسبس، عن طريق كمان فينا نقول الفيتراكتور.
Yeah, كنا we were
وبس
peeling the
بس
membranes
بس تمام.
بالforceps.
بعدين الشبكيه ضلت ساعتها تايت، ما عم تكون كومبليتلي ريلاكس. في الحاله هي بيكون عمليا بيكون في مثل تراكشن بالبريفري بالطرف الشبكيه اللي صعب كثير انه تو نقيمه او نشيله كومبليتلي. في الحاله هي دكتور طارق حط بي اس اي حتى كفلاته بريتني، بعدين سوى بسموها ريتينكتومي، ريلاكسنج ريتينكتومي. هو معناتها انه عمليا نحن عم نقطع المنطقه من الشبكيه اللي فيها كثير سكارينج، اللي ما عاد هي فانكشنينج، بس هي يعني عم تفصل الشبكيه حتى تو هاف ا هيلثي او تيشو. بعدين يعني سوى ليزر وحط سيليكون.
Exactly. شكرا انك لخصتها بطريقة اسهل. Yes. وبهي البيكتشر بفرجي هون المنطقة اللي عملنا فيها relaxing retinectomy هي كانت nasal، لأنه كانت رح تؤدي لريديتاتشمنت إذا ما عملنا retinectomy. وهون منطقة الترانسبلانت محل ما covering the macula. هو هي البيكتشر is under silicone oil still. وهون الترانسبلانت I don't know if my mouse is showing or no on the screen. وهون another view of the transplant.
Yes, it is showing.
Yeah. Oh, I'm just gonna show one last example here. This is a case we just did last week. Had a patient كان عنده giant retinal tear. He was operated on by one of my colleagues. بس صار بعدين عنده cataract. وصار ما بقى في view، بس مبين بالبي سكان انه عنده complete retinal detachment. So I did a phaco, cleaned the lens. Of course the bag was not intact, so left him aphakic. بعدين when I went in الريتنا inferior كانت كلها almost like macerated، يعني تحس فيها مثل multiple، هي detached و multiple breaks. So I didn't feel like trying to save this piece of retina was gonna give any advantage to the patient. So therefore we did inferior retinectomy مثل ما هلا قدمنا بهذيك الحالة. يعني عملنا relaxing retinectomy للlower retina. While we're doing this هو كان عنده كمان big macular hole. I created من الإدج تبع retinectomy a transplant and I moved it to cover the macular hole. So let me just play quickly this video. So here you can see already عملنا retinectomy inferior. هون بتشوف bare RPE. Let me just make this bigger. هلا هون هي الترانسبلانت هي جزء من الانفيريور retina. It was a little bit hard to pull لأنه you pull it against a bare RPE. Let me just make it here a little bit. هلا هون عم بتشوف الترانسبلانت. I'm moving it with a finesse loop above the retina. هذا كله كمان تحت ال PFCO. عم نحركها هيك باتجاه الماكيول هون. هو the beauty of PFO PFCL إنه it will help stretch the transplant. لأنه الريتنا tissue وقت تقطعه it can crunch on itself، ممكن تنكمش على حالة. بس ال PFO لأنه عنده great surface tension بيخليها open للtransplant stretched out. I'm trying to نسنترها بالposition تبع الماكيول هول. هون using vitrectomy just to eat the remaining part of the anterior retina بعد ما عملنا retinectomy. هون بهالبيت عملنا 180 degrees retinectomy مع laser.
يعطيك العافيه دكتور
شكرا
طارق.
طارق، ما شاء الله كثير يعني برزنتيشن حلوه وصراحه كيسات فيري انترستنج، يعني ما شاء الله عندكم يو ار فيري بيزي، عندكم فيري كومبلكس كيسز، يعني هذول عم تقدمهم كانهم ايزي وان. صراحه الحضور هذول موست اوف يعني فيري ادفانسد كيسز صعبين وفيهم كثير فينا نقول سيرجيكال سكيلز بقى. يعني ثانك يو فور ذيس نايس فيديوز.
Well, thank you for having me. Thank you for organizing this. And I'm happy to answer any questions now or in the future.